accurate and reliable food safety management system is a definite requirement of businesses to ensure high quality and safe food products in food, feed, and related industries. There's a risk of food contamination in every part of the food supply chain, from farm to fork. Therefore, control measures should be in place. From pre to post-harvest, processing, packaging, transporting, storing, and selling of food products. Food safety should always be a top priority. Competitive advantage in the market is achieved if the food producer has a conscious adherence to the global standards in quality assurance, especially on food safety. Glenwood is committed to help companies establish top-class food safety management system with technologies that are fully supported and approved by reputable institutions worldwide. Since its establishment in 1995, Glenwood Technologies International has been the leader in the exclusive distribution of premium rapid diagnostics and hygiene monitoring kits from trusted manufacturers worldwide, providing quality and technologically advanced products to meet the emerging needs for food and feed safety diagnostics, trusted by the country's largest companies and government institutions. Known as the pioneer in marketing rapid test kits, Glenwood continues to develop its product lines to provide reliable and immediate results in support of its clientele's aim to be globally competitive through conformance with the respective industries' existing local and international standards and regulations. Glenwood's core group of technical and marketing staff consists of top microbiologists, food technologists, chemists, and allied professionals in the food and agricultural fields. Combined with broad industry and regional expertise, Glenwood provides the competitive advantage necessary to deliver world-class excellence and best quality products at optimum service. True to its mission to uplift the food safety culture in the country, Glenwood took the initiative to publish the very first magazine on food safety and quality awareness from farm to fork. The Food Safety Trends Philippines magazine is regarded as the reference material of thousands of food safety professionals and students all over the Philippines. Glenwood helps to ensure that food safety is maintained in all parts of the supply chain, from farm to fork. With its superior products and optimum services, we help ensure that every food served to every Filipino is safe for consumption.
Sound check, sound check, sound check. Is the audio clear? You can use the comment section at the bottom part of your screen to let us know if you can hear us. If you are experiencing audio or video difficulties, you can send us a message via the comment section for our technician to help you address this. Good morning, everyone. I am Odina Fungo from Glenwood Technologies International Incorporated.
And I am Angel Dallo from the Institute for Food Safety Advancement, and we will be your moderators for today's session entitled Toronto's Efforts in Combating COVID-19 Pandemic, Sharing of Best Practices. Magandang umaga sa ating lahat. Good morning, Dean.
Good morning, Angel. For the past few months, globally, we have been sharing the same battle against an invisible enemy by the name of COVID-19, which has infected around 15 million people worldwide. We could say that now, more than ever, to emerge victorious against this virus, we have to brainstorm on the best solutions. And for that, we need to look at different perspectives. That is exactly what we will be doing today, Angel. Specifically, we will be hearing about the current best practices and future plans of Toronto, Canada, which as of the moment has around 90% recovery rate and a 3% positivity rate, which is within the World Health Organization recommendation of 5%.
That is correct, Dean. They're surely doing something right in their fight against COVID-19. For our audience, just a few reminders before we get started. The session is scheduled to end at 9:50 a.m., followed by a 10-minute open forum. If you have any questions for our speaker, please type them into the comment section below and we will be bringing them up during the open forum.
For today, Angel, I believe we have a very special guest all the way from Canada with us.
That is right, Din. Our guest for today is the Chief Medical Officer for Toronto Public Health, Canada's largest local public health agency that provides public health programs and services to 2.9 million residents. She received her degrees as Doctor of Medicine and Master of Health Science in Health Promotion from the University of Toronto. She also holds a Master of Business Administration from the Schulich School of Business. She is also an adjunct professor at the Dalla Lana School of Public Health at the University of Toronto. Without further ado, let us all welcome Dr. Eileen de Villa. Magandang gabi, Dr. de Villa.
Hello, and good evening, and good morning to some of you.
We are very grateful for the opportunity to talk to you about this very timely topic, Dr. de Villa, especially considering the 12-hour time difference. While it is 9 a.m. here, I believe it is around 9 p.m. there. Is that correct?
That's right.
Okay, so let's begin, Dr. de Villa. We have a couple of questions for you. If we are not mistaken, while the first case in Toronto and Canada in general was recorded late January this year, the first case of community transmission in the country was recorded early March. How was your experience when you had the first COVID-19 case in Toronto?
Well, it was certainly an uncertain time, and obviously it was something we were ready for. We were preparing for it since early January when we first heard about a pneumonia-like illness emerging from China. Mm-hmm. So it wasn't a surprise, but it's always, an interesting and unusual experience to have the first case of a disease that we were all still very much learning about. You'll remember that COVID-19, and at that time it was still called the novel coronavirus, it had just been discovered as a virus literally a few weeks before. Mm-hmm. So there was still a lot of uncertainty around the virus and certainly a lot of fear on the part of the public because we were hearing reports from China, but not, the information was still coming in small amounts. Because I think they themselves were also trying to understand the circumstances and to deal with a large number of cases. So I think that for us, we're used to dealing with communicable diseases and infectious diseases in public health practice, but a novel emerging disease always comes with a little extra, source of anxiety, if you will, because you're trying to understand what will we do. People are concerned about their safety. It does create a lot of attention from the media, which always adds a little extra, to deal with, a little extra, attention and scrutiny, which means you have to be extra careful when you're dealing with something new and different.
Yes, thank you for that, Dr. de Villa. What were the initial measures that Toronto immediately implemented to control the potential spread of the novel virus?
Well, in Canada, we have a number of different levels of government that have to work together. Certainly part of the process involves the federal government. They're in charge of actually managing the borders and they do the border screening. So they were responsible for those aspects. Our provincial government here is responsible for healthcare. So anything to do with the testing, anything to do with the actual laboratories and anything to do with clinical care, hospitals and that kind of thing are under their control. And for us as local public health, once it becomes clear that somebody actually does have a case of COVID-19 or any other reportable disease. We follow up with the case. We leave the clinical care to those in the hospital or in the clinical care system. But what we take care of is we make sure that we understand where might the person have actually acquired their disease and who might they have exposed, so that we can then follow them up. Make sure that those who might have been in contact with somebody who has COVID-19 during their infectious period is informed that they may have been exposed to an infectious disease. And also we make sure that they're given advice in terms of how to protect themselves and others around them, so that we try to control the transmission. So for us, with that first case of COVID-19, it was understanding what were the circumstances, where do we think that individual got their disease from, and who might they have exposed to COVID-19, so that we can contact trace them. This is now language that's very common to all of us. We talk about, case management and contact tracing. These are terms that we always use in local public health, but are now part of the common language in our world since COVID-19 has emerged on the scene. So that was our main course of action, was ensuring that we could understand where did this case come from. And in our case, our first case was travel related and did involve travel to China, in fact, into Wuhan. And so that's how we got our first case. And we made, fortunately, the individual did not have a lot of exposure to many other people. So it was a relatively straightforward case for us to manage as our first.
Okay. In relation to your answer earlier, I believe Canada also had experience from the first SARS virus. Would you say that this helped Toronto proactively prepare for COVID-19?
Yeah, I would say that there were certainly a number of lessons learned and improvements made within our local public health system as a result of SARS. And while this new virus that causes COVID-19 is is called SARS coronavirus 2, so it's seen as a relative, if you will, of that original SARS from back in 2003. It is a different virus, and it clearly transmits very differently. But while there were, I would say from the first SARS, there were definitely lessons learned, and there was an opportunity to improve many aspects of local public health. But these are, in fact, different viruses. Most notably, with that first SARS, it was largely contained to healthcare. If you were not, seen at a hospital, you were not a patient in a hospital, whether it's an outpatient or an inpatient, the likelihood of your exposure to SARS back in 2003 was actually quite low. So it was largely contained within healthcare. With this disease, with COVID-19 caused by SARS-CoV-2 or SARS coronavirus 2, it's throughout the community. And in fact, we see much greater spread throughout the world, right? We're at least at roughly 15 million cases globally now. We have not seen that with other coronaviruses in the past, whether we're talking about SARS or whether we're talking about MERS, Middle East Respiratory Syndrome, another coronavirus that has created some challenges in the past.
That is right, Dr. Eileen. Now, would you say that by now people in Toronto have become accustomed to the changes in their daily lives, particularly all the new health and safety measures being implemented, especially when they are in a public area?
Well, I think that people are certainly used to talking about the public health measures, and I would say, yes, increasingly getting used to practicing those public health measures. But I will also say this, I would say that it has required the cooperation of many people. And actually earlier in the introductory remarks, there was some mention as to a 3% positivity rate here locally. In fact, in Toronto, when we look at our positivity rate, our percent positive rate for tests right now in Toronto, when I last checked our results today, we're at actually 0.7%. So we've been able to drive the level of COVID-19 activity in our community down, certainly from its high back in April and May of this year. And I think that's because people have adopted these behaviors. They have learned how to wash their hands more often. They've learned how to watch their distance, keep 6 feet or 2 meters distance from other people. And as well, increasingly, we're finding people are more and more willing to wear a mask, particularly when they cannot maintain that physical distance. However, I think I would also say that people are also a little tired. It does get tiring, and it does get in the way of many aspects of the way we normally interact with each other. It's hard not to socialize with our friends. It's hard not to be able to go out for dinner in restaurants in the way that we used to before there was a COVID-19. And I think that there are many, many people who are eager to get back to something that's more similar to our life before there was a COVID-19. So as much as people have been critical to our success thus far, I know we have talked a little bit about in our community, and I know in communities all around the world, around this notion of fatigue from all the quarantine and isolation and public health measure fatigue. And I understand that. But I think we have to try and stay as vigilant as we can and really hope that our scientists will have some success in terms of finding new treatments and finding some effective vaccines to protect us.
On that note, Dr. De Villa, what would you consider as the most challenging situation the Toronto Public Health Agency has faced in this pandemic so far?
Well, so it's interesting. I would say that one of the most challenging decisions that certainly faced us at Toronto Public Health was actually having to make that decision that effectively shut down the city. I realized that compared to, a place like Manila, 3 million, a city of 3 million people is relatively small. But for us, this is Canada's largest city. This is the business center of the entire country. And to think about making a decision, which was the right one to make, but it's still a very difficult one to make. And when we're talking about a new virus, it's not like anybody has the exact answer. We've never dealt with it before. So we can look to others around, like we're doing here, sharing our experiences, trying to understand what others have done in a similar circumstance. But remember, most other jurisdictions were only a few weeks ahead of us in terms of their outbreak. So, you didn't really have the chance to see fully how well those public health measures worked. But we knew that we had to take that decision to effectively shut down our city, Canada's largest city. Very difficult decision to make. But now, with the benefit of hindsight, we know it was the right thing to do. I would say now our challenge is recognizing how do we live as safely as possible with COVID-19 in our community until we get effective treatments and an effective vaccine to protect all of us from the impact of this disease. I think that's the challenge that's in front of us now.
Okay, considering that, Dr. De Villa, I imagine that travel-related measures in this pandemic really is challenging. As of the moment, are there still travel restrictions implemented in Toronto? Are residents allowed to go back and forth different cities or provinces now?
So within Canada, you are allowed to go back and forth. There are certain provinces, certainly in Ontario, where I am, people may come from other provinces of Canada, and there are just the general prescriptions and protections around getting on board an airplane. Most of the airplanes are actually checking, screening passengers for symptoms. There are some requirements around mask use, especially while in the airports and on the airplanes. But other provinces in Canada do have some restrictions, and I don't know all of them because each one has a slightly different set of rules around travelers. However, if it's not for us between Canada and the United States, which is where a lot of our travel normally happens under regular circumstances, there's a lot more travel between Canada and the United States. It's a very, very long border between the two countries. And one that is usually traveled back and forth with great frequency. But now, unless it's considered essential travel, it's not allowed to happen right now, right? There is not as much, it's not to say that there's none, but there is not as much travel between Canada and the US at this point in time.
Okay. Also, considering our conversation earlier on the fatigue and quarantine isolation fatigue, despite our good intentions, we know that there may be a chosen few people who will choose to disregard the measures that we implement due to various reasons. How does Toronto deal with these individuals? For example, those who are not willing to wear masks in public or observe social distancing in public areas?
Yeah, these are always some challenges that we have, and I don't think that's unique to any one country. I think it happens in every part of the world. But I can tell you that our approach here in Toronto is even if it is something that is legislated, and we do have, for example, a mask bylaw here in Toronto. So it is a matter of a legal question, and it's a requirement here for businesses to have a policy to ensure masking in indoor public spaces. So our approach is largely around education, right? We believe that if we communicate well with people, why we're asking them to do things and why certain bylaws have been put into place, it allows people to make better decisions and to appreciate why they're being asked to do something. And I think if people can understand what the value of the action we're asking them to do is, they're more likely to do it. That doesn't mean that we won't enforce. We try not to. It's sort of a graduated enforcement process that focuses primarily on education and discussion first. And of course, we also rely a little bit on our community to help encourage each other. We know that if everybody else around you is wearing a mask, you're more likely to do it yourself. So we do rely a little bit on, I guess, positive community peer pressure, and use that to add on to our educational efforts. And so far, we have been pretty successful, I would say. There's never 100%. There's no such thing as perfect. But I would tell you that in order to be able to get to that 0.7% positivity rate on our current COVID-19 tests, we know that enough people, a majority of people, really have to be following our public health advice in order to get us to this situation compared to where we were just a few weeks ago.
I'll have to agree with you on that. Well-informed individuals will typically do what they're being told because they know why, as opposed to being just told that they have to. Now, the peak in Canada seems to have been around May in terms of daily cases. From that point onwards, your city has seen, or your country rather, has seen a consistent decrease in new infections. Aside from these decrease in daily new cases, what other factors should we account for before we can conclude that we have indeed flattened the curve?
Yeah, so what we have here, and I would encourage people to certainly look at our website at Toronto Public Health. Toronto.ca/COVID-19 is the website where we keep all of our information to help inform our public. And on that website, you will find that what we have, and this is specific to Toronto, is a monitoring dashboard. So we are actually monitoring a number of different indicators to help us determine what course of action we should take next. And we share those indicators and how we're doing on those indicators with our public, again, in a very similar fashion to what we've been talking about around education. If we show people this is where we are, this is what's happening in our community with respect to our response on COVID-19, that helps people, understand why we're continuing to ask them to take certain public health measures, why we're asking them to wash their hands, why we're asking them to watch their distance, and why we're asking them to wear their masks, particularly when that physical distancing is hard to maintain. So on our monitoring dashboard, we look for 4 major categories of indicators: virus spread and containment, to give us a sense as to how much activity there is in our community by looking at the 7-day moving average on new cases. We look at hospitalizations, that kind of thing, and outbreaks. How much are we having by way of outbreaks, either in healthcare settings or in congregate settings in our community. We also look at laboratory testing capacity. How quickly are the labs able to turn around tests, and what kind of percent positivity rate are we seeing with our COVID-19 tests? We also look at healthcare capacity because, of course, we want to make sure that our healthcare system is available to provide the care that people need, whether we're talking about medical care related to COVID-19 or medical care related to any other condition, right? If our hospitals are full of COVID-19 patients, then they're not available for people who are suffering from cardiovascular disease, heart attacks, or stroke, or other medical conditions that people have to use a hospital for. And then finally, we monitor for public health capacity. We are reporting on a regular basis to our public on the turnaround time for public health to get in contact with cases, newly identified cases, and new contacts. So we expect that public health should be able to follow up with new cases and their contacts within a 24-hour period if we're to be successful in containing the disease. So we follow these indicators and we report on these indicators to the public so that they understand what we're looking for, how we're making decisions around what actions we should take next, and so that they also understand what our progress is like in terms of our COVID-19 response.
Okay, so education and transparency is really key to implementing a successful measure for COVID-19.
Absolutely.
Right.
Okay, Dr. de Villa, I believe that right now, considering social media and all, information transfer is very easy nowadays, that even the wrong information often gets a wide reach. What is one of the worst misinformations you have encountered with regard to COVID-19?
Oh my goodness, there's quite a few of them, but I would say that as of late, the interesting thing and the interesting angle, if you will, on the misinformation that's out there has to do with masking, and to a certain extent, even now with vaccine, as vaccine is coming forward. So as of late, in the last few weeks, I have heard more and more about people talking about the dangers of wearing a mask, that, you know, you're not getting enough oxygen. And again, the kind of mask we're talking about here, I'm not talking about N95. We're talking about a cloth mask, which is what we're advising most people in the general public to use, particularly when they are in indoor, closed public spaces where physical distance cannot be reliably maintained. So when you go into a store or a mall, for example, you know, at one moment it can be fairly loose, you know, lots of space. And then all of a sudden, you know, before you know it, it can get quite, crowded with people. That's the nature of many of the shopping malls and stores that are out in our community. So we're recommending in those spaces, actually, we have a bylaw, I should say, that requires people to wear a mask in those spaces. And we're talking about cloth masks. And there are some people who are saying, for example, that wearing a cloth mask for an extended period of time is actually bad for you because your oxygen levels get too low and you're rebreathing stale air. And I've seen some things that suggest that it's bad for your oral health, that it will create dental and oral health conditions. And there is actually no basis to this whatsoever. And we don't yet have a vaccine. We know that there are a number of research groups all over the world really working very hard on this. And already we have seen, stories and reports that people are saying that, you know, the vaccine is dangerous, that it's, inadvisable to pursue that vaccine and that you should be afraid of it, that it won't be well tested, that, there will be challenges associated with it. So certainly those have been some of the types of misinformation we've been hearing as of late. Some of the other stories, of course, had to do with earlier on in the outbreak and in the pandemic, that COVID-19 actually had something to do with 5G networks. That was going around as well on the internet. You probably saw that because that was a global phenomenon. It was a story that, as is social media, that makes the rounds all over the world. And then there was, there were some stories again around how it was a kind of a bioterrorist type event and that it was purposely released from a laboratory. So these are some of the stories that have certainly been out there. That's why I think it's really important that we focus as a community, as the scientific community and as a public health community, I think it's really important that we put out education, that we try to put it in as simple language as possible so it's accessible to everybody. And then, of course, that transparency and accountability to the public. I think that's how we dispel misinformation, how we gain public trust and confidence, and how we make sure that people, focus on the information that can actually help them and help us as a global community to get past this. I think the misinformation can be quite divisive, and we have to really focus on recognizing that the solution to COVID-19 means that we have to work together. If we're to be successful, we actually have to work together as a global community. And thankfully, we have seen this manifest in the vaccine research efforts to date. That kind of thing, I think, is really where we need to focus our efforts.
I'm just curious, Dr. de Villa, do you also have some misinformation on maybe home remedies, like maybe consuming a megadose of vitamin C? Or here in the Philippines, we have this practice called tuob, or steam inhalation, to somehow relieve the person of the symptoms. Do you have such things in Canada going around?
I have not seen as much of that. I have, however, seen COVID-19 parties where people think that, they should just expose themselves to COVID-19 and get it over with. And, unfortunately, that doesn't always work out well for people. For some people, right? COVID-19 is not as severe an illness as it is for others, but we have seen, many deaths around the world associated with COVID-19. Admittedly, most of them in the older age demographic, but not exclusively so, right? There are young people that have died from this disease. So, it's not to be taken lightly. And it's unfortunate that there is still some misinformation out there. And I think that just tells us that we need to put out more appropriate information in a way that people can actually grab onto it. And it means also that we actually have to target our information campaigns to different subpopulations, recognizing that different messages appeal to different segments of our population.
I see. How about the vitamin C megadosing that Din mentioned earlier? Because I do know that there are some people, healthy individuals, who are not showing any symptoms of COVID-19, who elect to take high dosages of vitamin C to protect themselves. Because I do understand that eventually this will lead to kidney problems, right?
So, I think at the end of the day, when it comes to anything that sounds too good to be true generally is too good to be true, right? I wish I could say that there was a simple solution for every, disease or ailment. And, as it turns out, that's just not the case. And I think when it comes to something like vitamin C in particular, anything that is actually in excess of what your body needs just gets excreted. So, unfortunately, I think what it does is it, some of those cure-alls or panaceas that people advertise as the solution to whatever the disease is. In this case, we're talking about COVID-19. But people are, and there are individuals who will sell or seek to peddle what they say are the silver bullet to any number of diseases. As I said, generally, and not exclusively, but generally, anything that sounds too good to be true is usually just that, too good to be true. I wish I could say that there was a simple solution for many diseases and problems, but it's unfortunately just not that easy.
I see. Now, going back to what we discussed earlier regarding the face masks, is there a recommendation on the type of mask to wear? For example, when you are going to a high-risk area, for example, you really have to go to the hospital. Is it recommended to use an N95 or a higher type of mask?
So, when it comes to masks and personal protective equipment in general, I can tell you that the scientific evidence is the strongest for the use of personal protective equipment, including masks, but it does include a range of other products, gloves, depending on what the circumstance is. It may include face shields. But those are occupational health and safety questions, and the greatest evidence is available for the use of those types of personal protective equipment in healthcare settings by healthcare providers in order to protect them from the potential diseases of the patients that they're treating. But they need to be appropriately trained on how to use that equipment, and they must follow that training in using that equipment. When it comes to the general public, the evidence is a little softer on this in general. But what is recommended for the general public to use, again, within the regular context of daily life, it is reasonable to ask them to use a cloth mask. And the best kind of cloth mask that's out there is one that's usually a natural fiber, cotton or linen, usually double layered, and you want it to be reasonably well fitted to your face without big gaps, so that the material's not gaping wide open. You want it to be relatively fitted to your face, not tight, but just close up to the face. That's what we're recommending. And I think that it's also important to note that when we're asking people to wear cloth masks, it's not so much to protect them from other people, but it's largely around preventing the droplets that you might be putting out from getting out and exposing others. So the way we talk about the cloth mask use is to say that I wear my mask to protect you, you wear your mask to protect me. So it's a bit of a community effort, and we all need to wear our masks. When it comes to going into a hospital, I think the issue is that if you're going to a hospital as a patient, I would use here, what we're recommending to people is to use their cloth mask to start off with. You register at the hospital and then follow the infection prevention and control advice that you're being offered by that particular hospital setting. And it may vary from setting to setting or which specific aspect of the hospital you're using. And it also depends on why you're going to the hospital in the first place. So, following the advice that you're given when you go to, by the hospital staff is the best thing to do when it comes to using hospital services. And when you're out in the general public, we recommend the use of cloth masks, but the notion is for you to protect others from your germs rather than having the mask protect you from others.
Okay. I'm also curious, Dr. de Villa, how about wearing face shields without face masks underneath? Do you have some cases?
So that certainly has been one of the, a lot of people have been asking about that because it is, let's face it, I think the challenge with masks is they're uncomfortable and they're just something that we're not used to, right? To be obstructed, you're wearing something on your face, it's hot. Even here, it's hot right now. It's harder to breathe, especially when it's humid. It's something that we're not used to doing here in Canada for sure. And so there's a change management process that has to happen associated with that. This is the significant behavior change we're asking our population to adopt. So many have looked at a face shield because it's easier to wear. You don't get the same sort of obstruction to your breathing. You can see the face, which is what most of us are used to having as well. However, the science on this shows that there is not as much, you don't get as much blockage of the droplets from you to others by wearing a face shield. And that's fairly obvious. That's why we when we tell people to wear a cloth mask, we suggest that there should not be a lot of gapping, right? It should be fairly fitted to the face because that's what keeps the droplets in. With a face shield, there is lots of open space underneath, so the droplets can actually readily escape. So we know that face shields are good in terms of adding extra protection for the eyes, but only if done in concert with a mask. By themselves, they're not meant to be a substitute, and they are not a good substitute for a mask.
I see. Dr. de Villa, what about those masks with one-way valves? Do you recommend using that, or?
So when I last looked at the literature specifically on this subject, it's not seen as actually a help to have that one-way valve. And again, what I'm going to remind you of is when we're talking about cloth masks, we are not talking about wearing the mask to protect yourself from the germs of others. We're actually talking about protecting others from your germs, which is why we all need to wear the mask together. The more of us are actually wearing the cloth mask, the more we're able to create a safer environment for those in our community, because I wear my mask to protect you. You wear your mask to protect me.
Yes. Dr. De Villa, in a fairly recent development, the World Health Organization has acknowledged evidence of possible airborne transmission of COVID-19. How do you think will this change current control measures that we are implementing?
Well, I think that this is one of those interesting debates, and it's all around the exact wording. And I don't want to get overly technical with this. But when it comes to what they're talking about with the transmission of COVID-19, the issue is that it is largely spread by close contact with somebody who actually has COVID-19 infection. And the major issue is around what comes out. They're called droplets, but they're so tiny, they're microscopic. What comes from somebody's nose and mouth, when they talk, when they cough, when they sneeze. These are there are droplets that come out of people's mouths and noses when they do this, and it's exposure to that actually gives rise to a COVID-19 infection from one person to the next. When we're talking about airborne transmission, traditionally in the world of infection prevention and control, we're talking about disease agents that can hang in the air. They're so tiny that they can hang in the air for hours. This is not what's expected of and not what's understood of COVID-19. We've seen that it is able to hang in the air for probably in the range of minutes, but not hours. So when we're talking about, is it airborne, is it droplet spread, it's largely this scientific academic debate. And for the public, the simple thing to understand is really what we call the 3 C's, right? COVID-19 is likely to transmit and you are at higher risk of transmitting or COVID-19 if you are an infectious person, you actually have a COVID-19 infection, and you are in a closed space with crowds and with close contact. Right? These are the circumstances that people need to understand, put them at higher risk for COVID-19. When you're in a large group of people in a closed space with close contact, where you're not able to maintain, reasonable physical distance at minimum 6 feet or 2 meters. Those are the circumstances that are likely to lead to COVID-19 transmission. Add to this the challenge that people are able to transmit COVID-19 infection when they are either pre-symptomatic, so before they even start to have symptoms, and for some people, their entire infection will be asymptomatic, that they don't have any symptoms, but in fact, they have a COVID-19 infection and they are able to transmit. So these are the things that people need to understand. The rest of that debate, the admission by WHO and their acknowledgement of how COVID-19 transmission occurs, and their change on their stance on this issue is largely one for scientists. What we need to know: asymptomatic and pre-symptomatic people can transmit COVID-19, and that transmission is most likely to occur. It's there's higher risk of its occurrence in crowds, in close spaces with close contact.
Aside from the obvious effects in our health, Dr. De Villa, one of the dilemmas all nations have faced is the impact of the pandemic on the economy. Essential businesses have remained open, and now, half a year into the crisis, additional businesses are transitioning into the new normal. How did Toronto go about with the resumption of the different industries?
Well, that was an interesting question. When we did have to make recommendations And it started first with recommendations to shut down certain businesses. And ultimately, it was the provincial government that issued an order to close down businesses and made the designation of what was essential and what was not. And that was done in consultation with local public health officials, myself included. And I think quite simply, because there were other jurisdictions that were a little ahead of us in terms of their outbreak, we had the opportunity to take a look at, well, what did other jurisdictions deem essential and what did they find actually worked in their circumstances? So, for example, New York City and New York State, I should say, had shut down much of the activity in that state before we did. So we were actually able to take a look at what businesses they deemed essential to help inform our own decisions here. But you know, it largely centered around, so what resources, what services, what activities need to continue in order to allow us to effectively survive. So you knew you needed food, you needed medicine, there needed to be certain industries that are related to the transportation of food, for example, that needed to stay open. And it did change over time, as it should, right? As you learn more information, you change your practice. That's, I think, very simple professional practice. And that's exactly how it played out here. So there was, there were decisions made around which businesses would stay open. And in fact, even over the course of those early weeks, the list was adjusted. Some construction was originally allowed, and then the list got a little more restrictive, and only certain construction projects were allowed to continue during that period of shutdown. Essential construction, like the most important construction projects, were allowed to continue, and others that were deemed as having some capacity to wait were put on hold for a period of time. That's just one example.
You mentioned earlier that transparency in education is very important to control COVID-19, or has been important in your efforts in Toronto. We're just curious, how about contact tracing? How did you implement contact tracing for areas with a high volume of people, for example, public transportation?
Well, you know what's interesting is, and I was just talking about this earlier today to another group, of the 15,000-ish cases that we've had so far in Toronto, none of them have been linked to public transit thus far. That doesn't mean that there's no risk in public transit. It just means that we have not picked up any clusters associated with public transit. And in fact, the main risk factor that we've noted when it comes to transmission of COVID-19 in our community is close contact with a case, which most often occurs in the household. And the second most frequent place in which that close contact occurs is in the workplace. So these are our most common risk factors when it comes to COVID-19 infection in Toronto. With respect to contact tracing, at the very outset of COVID-19 and our particular experience with it here in the city of Toronto, we had initially 50 people working in case management and contact follow-up. We are now in that section, probably on the range of about 500, well, more like 600 people we have working in this particular aspect of our response. So from late January, early February, 50 people. Now here we are, mid to late July, closer to 600 people doing just that same work. And what this is a remarkable increase, I think, for any industry, whether we're talking about public sector or private sector, to increase your work ranks that quickly while you're in the middle of an emergency response. These are people that needed to be trained and needed to learn the information system in order to provide this response. But this is what the response required of us as a local public health department. And in order to fulfill our obligation to the public, we knew we had to do it. So we simply did it. We are continuing to recruit people because we did find that that was a significant ramp up for us. And so as a result, we had a number of people that really were working very, very hard for weeks on end. So we're continuing to recruit people so that we're ready for future activity of COVID-19. And we're going to, so that we'll be able to do that case management and contact follow-up in a timely way, while at the same time making sure that we're not burning out our staff, right? It's one thing to respond in that very significant way for the first round and for the first wave. But if we're going to try to live successfully and as safely as possible with COVID-19 in our community, then we're going to have to make sure that our response is sustainable, which means that we actually have to have more and more people, more reserve, more backups, more surge capacity to respond to increases in activity in the future.
Now, you mentioned earlier about herd immunity. I think you mentioned that earlier, right? Now, there have been articles saying that herd immunity is not promising for COVID-19 because some IgG positive individuals eventually lose this titer level and some even get reinfected. What are your thoughts on this, and do you think this will affect the vaccine development?
So, as I mentioned earlier, new virus, right? Only sequenced, I believe it was January the 12th, if I remember the date correctly. And here we are, in mid to late July. So we've only been aware of this virus for a few months now, which is relatively short in the grand scheme of things. So there's a lot we still don't know. And this question of immunity is one that has yet to really have a final answer. We certainly know that people do develop antibodies after an infection, a COVID-19 infection. The question is, how long might the immunity that's provided from an infection last? And because the virus has been with us for such a short period of time, I think the simple answer, the simplest way to put it is to say, we actually don't know. You're right, there have been some cases written up suggesting that reinfection has occurred, but it's not entirely clear that this is common or that in fact what looks like reinfection really is reinfection. Science tends to be one of these areas where we want to be very certain, we want to be sure, and so it requires time to really come to definitive answers on any question within science, especially when we're talking about a brand new disease and a virus that was only discovered a few months ago. What does this mean for the vaccine? I'm not really sure. I don't think anybody really knows. We know we have a number of candidate vaccines throughout the world that are demonstrating some promise, but we really don't know when we have a vaccine that looks like it has some real potential to be used in a large scale. How many doses? How long will the protection last? These are questions that we still don't have answers to, but we certainly remain very hopeful for. I would also say this, most scientists, as I've understood it and heard them speak, will say that, look, even if the vaccine only lasts a year, even if a first vaccine only lasts a year or 18 months, that's actually not an unreasonable thing to take on as a protection. It buys us, some more time to, figure out, how do we live safely with this vaccine? Can we ramp up vaccine production enough that we can continue to vaccinate and revaccinate in a very similar fashion to what we do with influenza, right? When we have a flu vaccine, we do have flu vaccine. It is something that's actually required on an annual basis. So, if that's the best we're able to achieve with a COVID-19 vaccine at the outset, it still provides good protection, reasonable protection, while the vaccine research and treatment research efforts continue on.
Dr. De Villa, this is our last question for the interview proper. We know that in the past you have also played a big part in Toronto's strategy against various anti-vaccine movements. I think you also mentioned this earlier. Do you foresee that such movements will also be one of the hurdles once we obtain a vaccine for COVID-19?
Yeah, we're already beginning to see that. I did mention that earlier in this conversation, that we are seeing some anti-mask sentiment and anti-mask movements. But associated with that, we are also seeing some anti-vaccine proponents emerge and become more active and more vocal in public. So I do think that this is part of our effort in public health to ensure that we are putting out information that people can readily grasp and understand, and that we do it in a way that actually appeals to a broad range of interests. And sometimes that does mean targeting communications to specific audiences so that they can really grasp the message and so that that message really resonates with them. So I do anticipate that we will see some of that. But as with most things with COVID-19, we've found good cooperation from the residents of Toronto. In general, we have high acceptance of vaccine. Many people in this city come from countries from all over the world and have seen the negative impact of vaccine preventable diseases. So, I do think that there is generally a relatively high appreciation for the value of vaccines here in Toronto. And I expect that we'll continue to see that when it comes to the COVID-19 vaccine as well.
Okay. Thank you very much for that very enlightening discussion, Dr. De Villa. I believe we have some questions now from our audience that we will be accommodating.
We certainly do. However, due to the limited time, we will accommodate just a few questions. So, Dr. De Villa, are you ready for more questions?
Already.
Okay, so the first question is from Ms. Cheryl Hoban. So she's from the hotel, restaurant, and catering industry. What is your call on implementing the UVC light disinfection in hotels and restaurants?
So, that's an interesting question. And I admit I haven't done a lot of research on this, but I will say this. What we do understand now is that the vast majority of transmission is really around person to person. Somebody who's actually infected with SARS-CoV-2 or has COVID-19 disease, and close contact between that individual and others, right? This is a disease that's spread largely through droplets, sometimes very tiny, that can linger for a little while in the air. But its transmission from one person to the next is really fostered through close contact, crowds, and closed spaces. So to the extent that we can actually avoid those 3 C's, we can limit transmission. I think when we look at the environmental controls like UV light, there may be some circumstances where that's helpful, but I would focus most of the efforts on controlling the circumstances that allow for easy transmission. So reducing crowds, reducing close contact, and avoiding closed spaces as much as possible.
Dr. De Villa, our next question is from Mr. Jacob Inigo Salazar. What do you really mean when it comes to mass testing? How much % of the population do we really need to test?
Well, I think it's less about the numbers and more about trying to find the circumstances that are most likely to give rise to tests that are valuable to us. So certainly those who have symptoms of COVID-like illness should be getting tested. And I think the other areas that we need to focus on are those areas where we know there is some degree of transmission. What's interesting is that, in speaking to some of my colleagues here, when we've started to do any kind of surveillance testing efforts, we find in general that if there's no COVID, there's no COVID. If you're doing some surveillance testing and you're not finding much, stop testing there. The interesting thing is that the corollary to this is that if you find a little bit of COVID, chances are there's a lot more there than what you think. So, because we do find that it is quite transmissible. So to my mind, the focus is less about the absolute number of tests that are being done, but ensuring that you're focusing on testing in the right circumstances. And that is with symptoms especially, but also in areas where and you have some documented cases, because once you've got some cases, that there's more behind that. And that's the area to focus on.
Okay, our next question is from Mr. Francisco Lozada, Gutib. How is Toronto dealing with safety protocols in schools, colleges, or universities?
So these are still very much in development, and the answers are, still in the offing in the future. Schools start here generally in September, and they have all been asked to come up with plans by early August that will be discussed at the provincial level of government. But I think if there's one thing I can say, we're still learning a lot. We know that younger kids tend not to transmit as well. Older children, middle school age and high school age, transmit. It seems so far, the science would suggest that they are able to transmit in a fashion similar to adults. So there's a lot of talk around, should we cohort kids? Should we use smaller class size? In the Philippines, you have the advantage of weather that allows for people to have windows open and more ventilation and fresh air. Here in Canada, we can probably do that about the end of September at the latest. After that, our weather becomes too cold to allow for those kinds of circumstances to happen. So there's a lot of talk here around what we can do to control transmission risk within schools. But to my mind, the best thing we can do right now to support the likelihood of safety in schools as the school season approaches for us in September is to reduce community spread. So to the extent that we can reduce the amount of COVID-19 transmission in the community and COVID-19 activity in the community, that will promote the likelihood of success for resumption of school, whether we're cohorting in small classes or reverting to something that is more similar to regular size classes.
So for the last question, this is from Mr. Jerry Safra. What positivity rate level would you consider as an indicator that measures a country is doing or implementing are effective?
Well, certainly the WHO right now is promoting a rate of 5% positivity or percent positivity in testing or less. As far as I'm concerned, when I look at our numbers here in Canada and where we've seen good success, clearly you're trying to get it down below 1%. Even with that less than 1% percent positive testing rates, we are still seeing cases. And the challenge is that it is difficult to bring those rates down. The decline in the number of cases actually is slow and gradual. So it's a very challenging virus to manage. And of course, the challenge is, like all viruses, it continues to change and mutate. That's part of how virus transmission works. And we are noting that it is a rather transmissible virus. So I think clearly the aim is to get that number down as low as possible. And it's interesting to note that at the outset of the outbreak, the WHO had the goal in terms of percent positivity at less than 10%. They've now moved to less than 5%. And I think that's because we're seeing that, in fact, you really need to, do a lot of work, and you want to see those numbers come down as far as possible in order to demonstrate good control.
Thank you, Dr. de Villa, for taking the time to answer those questions. I hope it further helped our audience understand the topic even better.
So before we end, is there anything else you wanted to cover before wrapping up, Dr. de Villa?
Well, first and foremost, I wanted to say thank you to all of you. One, for inviting me, and two, for your attention. I really do appreciate it. And every talk I do on COVID-19 now really does end with the W's, right? I remind people, please, right? The best thing you can do now, wash your hands, watch your distance, wear a mask, and work together to take care of each other. I do think that one of the most important things that we can do in our COVID-19 response is to be kind to each other. This is a time for working together and for really coming together as a global community, because that's what it will take in order for us to be successful in our response.
Thank you very much, Dr. De Villa, for taking time to talk to us despite your busy schedule and the time difference.
Thank you again for having me.
Okay. So again, everyone, that was Dr. Eileen de Villa, Chief Medical Officer of Toronto Public Health. We would also like to take this chance to express our gratitude to our Chief Executive Officer, Mr. Red Ochoa, for extending the invitation and coordinating with Dr. De Villa, thus making this session possible.
Last but certainly not the least, we also thank everyone for participating in our session today. We appreciate you being here with us virtually. Should you wish to see more information on the Toronto response against COVID-19, feel free to visit www.toronto.ca or follow the Toronto Public Health Agency on Twitter at TO Public Health. We want to know how we did with this webinar. Kindly fill out the feedback form that will be provided in the comment section after the session.
Thanks again for joining us today, and we will see you next time.